Hello, thank you for the opportunity to share my presentation with you all. Today I'm going to talk about the management of the soft tissues. What's most important in our practice is the study of the treatment plan. Because if we do not evaluate meticulously all the clinical parameters, we can already anticipate failure. And for example, in this specific clinical case, we can easily notice that the distance between the implants and the number of the implants is not correct. And the soft tissues is lacking keratinized tissues. So it was predictable since the beginning that eventually the patient would have come to this situation, as we can observe in the picture at the bottom right side. Consequently, is an induced peri-implantitis. The peri-implantitis are a multifactorial disease. There is a periodontal peri-implantitis and an induced peri-implantitis. For the induced peri-implantitis, the reason could be surgical, incorrect implant placement, incorrect management of the soft tissues and the hard tissues, or prosthodontics, incorrect functional loading, incongruous prosthetic frameworks. As far as the peri-implantitis, in this specific case, I will talk about and examine the complication that could occur to the soft tissue. So, the peri-implantitis periodontal, we have to remember that the etiopathogenesis of the peri-implant disease is similar to the advanced chronic and aggressive periodontal disease. This is an extremely important research because it's one of the very few studies in which patients with generalized aggressive periodontitis were treated with implants and compared to periodontal healthy patients, and also patients with chronic periodontitis. And we can clearly see here in the graphic showing a complication and bone loss over a 3 years time window. It was more severe in patients affected by generalized aggressive periodontitis compared to patients with chronic disease and healthy one. This means that before thinking about any surgical implant approach on patients with periodontitis, we must make the correct diagnosis based on the type of periodontitis. What I can say, according to the Italian law, and probably most other countries, the underestimating a patient with periodontal disease and lacking the right periodontal treatment leads to malpractice. What we do now under a periodontal point of view is that chronic periodontal disease and aggressive localized periodontal disease, if treated correctly, will result into a positive prognosis, while the aggressive localized left untreated will definitely result into an aggressive generalized case. And an aggressive generalized cases, even when treated, will have an uncertain outcome. So when we have to treat this kind of patient, the steps must be the diagnosis, which has to be executed with a periodontal chart and eventually using microbiological samples that can be useful to determine bacterial type and executing restorative therapies and eventual extraction, periodontal treatment alongside patient compliance, and then, at the end, execution of eventual surgical periodontal treatment, and after all this, execute implant therapy. Because we have to keep in mind how most of the treated patients, 80%, will experience peri-implant mucositis, and that between 28 to 56% of our patients will have peri-implantitis. And what can be done in peri-implantitis? Surely the first approach would be surgically. Decontaminate the implant surface to clear the infection, but there is no scientific evidence. And there is no scientific evidence about the correct decontamination technique, nor about an eventual regenerative technique to be used to correct peri-implantitis with the intragony defect. But we know that peri-implantitis is an irreversible disease because from morphometric studies, we know that once the implant surface is contaminated, it will show carbon dioxide. And this is meaning that the surface is corroded and no reosseointegration can take place, but eventually only ossification. That can cause an improvement, absolutely an improvement of clinical parameters. In this clinical case, the patient comes in for a follow-up 4 years after the surgery, after missing all the recall systems. So I decided with the patient to remove all crowns on the implants and execute a regenerative technique with bios, bioguide, and adding and again. During the surgical re-entry to reinsert the crowns, I was pleased observing the positive results that you can see on the left pictures, although we know that is not a Ross integrative process, but only an ossification process around the implant. Then, to avoid generating peri-implantitis, a correct surgical approach must be determined through a great knowledge of surgical technique and a deep study of soft and hard tissues. And in this speech, we will examine how to handle the soft tissue. We have to recreate the biological context to make sure of the stability over time. So in other words, the surgical approach has to match the parameters of the periodontal surgery. For example, in the study, the authors showed how, in order to achieve stable soft tissues, over time we need to have a lot of keratinized tissue, avoiding tissue recession. This will allow us to have crest bone stability without bone resorption. Certainly, if we have a thin peri-implantitis tissue, we'll have a higher risk of resorption compared to the thick tissues. So, the soft tissues integration definition, we have to remind that is a biological process that happens during the building and maturation of the link between soft tissues, connective and epithelium, and the transmucosa portion of the implant. And we have to keep in mind that peri-implant tissues are similar only as far as the shape is concerned, but the connective tissue close to the implant is relatively acellular and non-vascularized this area, which is more attacked by bacteria and mechanical process, is also the area with less fibroblasts and circulation. The theory confirms that peri-implant tissue must be stable and fixed with a sufficient quantity of keratinized tissue to avoid recession moving forward. And how do we determine whether the tissue is a thick biotype, at least 2 mm thick? Well, using a periodontal probe into the sulculus, thick tissue, the periodontal probe is not visible. Then the tissue is considered thick. And Croix teaches us that if we have to consider risky patient, the patient with a thin biotype, with heavily festooned, badly positioned teeth, triangular-shaped teeth. Obviously, we can consider all as low-risk clinical cases, all the opposite cases, such as the thick biotype, lowly festooned, gingival shape, and all other parameters. Therefore, we have to take in consideration all those parameters, knowing that if we have a thin biotype, we have to contrast the possible loss of soft tissues caused by implant therapy and prosthetic procedures. While in case of thick tissue, we have to execute invisible incisions, like intrasulcular, without traumatizing the papilla, because the thick biotype has inclination to non-aesthetic incision lines. So the decisional criteria to manage soft tissues are surgical procedures, incision technique, and connective tissues graft. So for the surgical technique, for patients with a thin biotype in aesthetic areas, we have to plan the mucoperiosteal flaps for the following reasons. We have to preserve blood supply, give access to the local bone collection, and give a surgical seam far from the implant sites and from the increasing areas. The implant therapy requires a surgical procedures that needs to be considered plastic and reconstructive. Barely visible incisions, allowing incisions without tension, preserving the circulation of the flat margins. So the curved-chamfered incision and abbreviated-chamfered incisions. For the curved-chamfered incision, the curved needs to start under the tension of the alveolar mucosa to the interdontal papilla, distal to the edentulous space contiguous teeth. Then it goes sinuously in the adherent gingiva, finishing pericrestally on the palatal side. The incision must be chamfered, blade oriented to the center of the flap with a 45-degree angle with the tissue surface. Mucosal tissues and adherent treated with the chamfer technique tissues consent to have more contact surface and healing without scars. For example, this is a 40-year-old patient coming to the office for a fracture of the central left incisor. The patient had a thin biotype. I executed an incision under the tension of the alveolar mucosa to the interdental papilla, and I regenerate the bone defect and increase the soft tissue. We have to increase the soft tissues using connective, in this case, connective tissue graft. Keep track of the healing process, and after having executed the implant therapy with fatness technique, this is the result after 5 years. I care about showing you how the incision technique permitted to achieve a satisfactory aesthetic result. Next clinical case, this is a 50 years old patient at the clinic for the fracture of the same central left incisor. Still to notice the incision lines, we can see vertical and horizontal bone defects with basins of the buccal plate. So the bone regeneration with non-observable membrane was executed with bone chips extracted from the cheek branch pillar to increase the volume of the tissues. Then I pediculate a connective tissue. For the surgical re-entry to remove the non-reabsorbable membrane and insert the implants, we can notice in the right top picture the bone regeneration achieved. Just as in the two pictures, we can notice before and after the amount of the mucosa tissue obtained without scar tissue. Another incision technique for the thin biotype is a case of, in this case, for example, of monodentulia. It's the brief incision. In this case, the bone's penetration has been handled with an only bone taken from the anterior nasal spine, which mixed with maxi reserve. Allowed regeneration on the pocket. To avoid the non-aesthetic outcome thick biotypes caused by linear incision, intrasulcular technique would be recommended. In this short video, this is specific case I had to execute an extraction of the second premolar on the top right side for an endodontic failure. So we can see the intrasulcular incision technique having a correct finger position in relation to the blade, so it can enter parallel to the vertical tooth axis. The distance is to be determined having a correct holding point using the right oral retractor. Other clinical cases for intrasulcular incision: 45 years old patient with aggressive localized periodontitis was treated with periodontal therapy. Once the patient compliance was in place, we could proceed inserting the implant in area 3.1 alongside a regenerative technique with endogain for intrabony defect at the distal wall at 3.2. We can observe through X-ray the bone amount obtained and the filling of the bone-like defect on the distal wall of the 3.2. Another intrasulcular incision case of thick biotype, compromised teeth caused by invasive cavity process that could not be handled with crown lengthening surgical procedures because of short trunk root with a very high furcation after executing an atraumatic extraction, allowing us to maintain the 4 alveolar bone walls intact. We have to be careful to preserve the papilla. For example, in this case, I stitch it. After this, I proceed to insert the implants immediately after the extraction in an ideal position, filling the infrabony defect using heterologous bone and positioning 2 layers of resorbable membrane to undergo epithelialization of the peri-implant tissue. And this is the result after 5 years follow-up. Next clinical cases: 40 years older woman, aggressive localized periodontitis, loss of 3.2. What we can see in the X-ray is the presence of very, very thin alveolar bone process on contiguous elements. These are the prosthodontic steps, and this is the result. A follow-up after 13 years, where we can notice a good integration of the crown in relation of peri-implant tissue, and comparing the X-ray, we can see a good bone regeneration thanks to the thin alveolar bone process on the contiguous teeth. Among the decisional criteria, we have to understand when to use connective tissue grafts. When we have to handle the soft tissue with connective addition, we have to ask ourselves for a correct planning treatment to avoid failure. When, why, and how. When always when we have a thin biotype, absence of residual keratinized tissue, why half and long-term recessions to avoid this, and how sampling techniques versus membranes. It's extremely important in implant therapy to apply surgical procedures coming from a periodontal surgery. Connective tissue graft can be taken from different site spots, such as the palate, edentulous areas, mucoperiosteal, flap, and tuber. On the palate, in the withdrawal of connective tissue from palate, the most important factor for the donor's side is the palate vault. A flat one has minor amount of connective tissue, and this can affect the increase of the keratinized tissue. Then we need to regenerate, therefore the use in this type of anatomic situation using collagen matrix membrane, as we'll explain later, can be a good solution. To get the donor site ready, we can make linear incisions or angular ones, or withdraw free gingival graft. In this clinical case showing connective tissue graft to treat multiple polarization on the central incisors and Miller third class on the 2.1 with angular incision technique, the donor site, executing a flap with papilla preservation, and this is the result after 8 years. Next clinical case, another angular incision, in this case was executed for multiple Miller second grade recession and a tunnel technique. Healing and checkup after 3 years. Still in the angular incision technique, 27 years old woman came to my office after having had an implant therapy on 1.1. What was obvious was the poor execution of the surgical technique, causing the atrophy of the distal papilla. The only solution for this case to augment the volume of the distal papilla is to execute a pedicle connective graft using an angular palatal incision. This is the before and after. We can appreciate the augmentation of the distal papilla with barely visible scar that would have been easily taken care of with an desepithelialization, but the patient decided not to undergo another procedure, and she was very happy with this result. So the incision technique for free gingival graft, I'm showing you a short video to avoid this kind of situation, like dramatic. I think I'm starting, yes, the video. Then the first linear incision after measuring with a periodontal probe the amount of tissue needed, exactly like this. So execute the 2 vertical incision depending on the amount of the keratinized tissue needed. That. So at this point, I insert the blade horizontally to separate the subepithelial layer from the connective tissue underneath. And finally, to be absolutely sure separate the layer from the connective. I'm checking it. And then I executing an horizontal apical incision and remove consequently the Periodontal graft. That will be initiated. Now is the moment that I remove the Periodontal graft. So this is the technique for the Periodontal graft. And I told you, consequently, the Periodontal graft that will be disepitheliated. Okay, ready? Next one, thank you. So the difference in the choice of using connective tissue graft versus gingival graft can be given by the thickness of the palatal masticatory mucosa. From the latest clinical data published by Zucchelli, it seems that gingival graft tends to augment in volume over time, as if the epithelial component of the addition favors to the production of new epithelial layers in the additional area. In case of possible bleeding complication, we have to immediately execute a compression of the area with a constant pressure for 5 minutes, applying surgical stitches, or in extreme arterial complication, we have to localize the vase, increasing the extension of the flap to tie the vase. That is a very deep complication. Scientific research is giving us a first guideline to have the chance to use substitute soft tissues for increasing the volume of soft tissues. An alternative to the connective tissue graft and free gingival graft that I have been using is the Mucoderm porcine collagen tissue matrix. There is many studies showing the possibility to use this type of membrane to augment the volume and quantity of keratinized tissue. Other case report also to increase the covering the gingival recessions. And based on these evaluations, I began to treat patients using Mucoderm instead of autogenous graft. For example, in this clinical case of a 50-year-old patient came to my attention for his compromised situation under a reconstructive and gingival point of view. So before approaching the reconstructive surgery of the soft tissue, my team prepared the patient for a periodontal and restorative approach. At that point, I was able to execute a mucogingival surgery to regain a Miller second class on 2.3 with Mucoderm. This is a follow-up after 1 year. We can show the difference between the before and after. So another clinical case, second class Miller on the 4.6, lacking keratinized tissue, and the Miller first class on the 4.3. Preparation of the flap with papilla desepithelialization, application after having prepared the membrane with the length and width and width desired. At the bottom pictures, we can see that temporary crown was reduced on the new prosthetic margin. Picture of the finished result of the clinical case, where we can notice the augmentation of the keratinized tissue that took place on 4.6, where is clearly visible the distance with the mucogengival line, and also the resolution of the first grade gingival recession on 4.3. Patient with edentulous on 2.6, 2.7, where we can notice the absence of keratinized tissue in addition. The patient had a pneumatization of the maxillary sinus. Therefore, I realized the recovery of the maxillary and increased the volume of tissue by the use of mucoderm. You can notice the picture on the right, the vertical dimension of the obtained keratinized tissue. Next clinical case, woman came to me for a fracture caused by the advanced cavity process on the 2.3 main bridge abutment with bone contraction where the dentulea used to be. I made insertion after extraction, while on 2.5, where we had an extremely thin bone, I execute a split crest technique, filling the remaining bone defects with bone, heterologous, and reabsorbable membrane. And to augment the volume, I added the mucoderm membrane. We can now notice the increase of soft tissue volume and the anatomy shape changes of the edentula area. Another clinical case, 14 years old woman with multiple second-grade recessions with severe abrasions. I show you another short video about the technique to put the mucoderm to cover roots. We are so incision with preparation for surgical papilla and flap preparation for the full split technique. Desepithelialization of the papilla. This is split. That the full. Then the scaling case. Garbage scaling. Then I try the length of the mucoderm and the right thickness. At this point, I use an envelope technique, stabilize the membrane, and then I start stitches. Important to use the stitches very well. So, next one. This is the result, follow-up after 24 months. And restorative dentistry. This is the final result. Other clinical case, 30 years old male patient with a fracture of a way of the root of 2.1. We have to consider that he kept the fractured tooth for 8 years with a splint to the next tooth. After removing tooth and infection, I executed regenerative technique, and in order to increase the volume of tissue and the contrast on an eventual contraction of the tissues, I immediately applied a membrane. In this case, the implant was delayed. On the top left pictures, through a checkup, CT scan, it is evident a good bone regeneration, both vertically and horizontally. 6 months later, the surgery, we also have a good stability on the volume of the soft tissues. In this other short video, this short video kind of sums up all I've been discussing today, the chamfered incision technique. And also to observe, because this is the phase and the step that I use to insert the implant. But I would check the regeneration of the bone tissue and the thickness of the soft tissues too, that I obtained with the regeneration using mucoderm membrane. With the inclination of the blade, to show you always the same technique. Here, I want to show you the bone regeneration and the thickness of the tissue. So, insert the implant. Then the next one. And this is the result. Check at 24 months. And you can notice the quality of the thickness and the keratinized tissue, which allows a good harmony with the emergent profile of the implant crown. Clinical case in which the patient, because of the absence of the 3.4 correct by orthodontics, presented on 3.5 and 3.6 a thin biotype with a beginning of recession, which was correct by the use of collagen membrane, always with nuclear. And this is the result. And the patient with an odontic lesion that could not be treated because of sclerosis of the canal. After extraction and regeneration, the membrane was applied. Healing after 21 days. And this is the follow-up after 1 year. We can see, observe the proper thickness and the profile of the crown in relation of the keratinized tissue. The peri-implant injury with defect of contaction of the contaminating the surface of the implant regeneration was performed to obtain ossification around the implant and increase the tissue, again using the membrane. And this is the control after 24 months. And we can observe a good thickness and the absence of inflammation. So we did a randomized clinical study. The title is coronally displaced flap with a free gingival graft or with collagen membrane for the treatment of multiple gingival recession without loss of interdental laxation. The aim of this study was to evaluate the clinical effect of the free gingival graft with a coronally displaced flap versus mucoderm with the same technique in treatment of multiple Miller class 2 recessions without having, as a result, a loss of interdent attachment. The material and methods have been included in the study on 13 patients in total. 7 have been randomized with in the test group CAF plus mucoderm and 6 in the control group CAF plus free gingival graft. In a single center that enlisted the patient from September 2015 to December 2015. The analyzed variables were complete root coverage and post-operative morbidity parameters. A questionnaire submitted to the patients and the clinical parameters 1 week, 3 months, 6 months. After 1 week, 3 months, 6 months, we have record the data concerning the post-operative pain, the number of analgesic anti-inflammatory tablets, the presence of dental hypersensitivity evaluated by using the spray of the air water serum, using the instrument VAS from 0 to 100 is the visual analog scale of the guideline of the Italian Society of Anesthesia. 1 week later, and 3 months and 6 months later, parameters to evaluate the complete coverage of the root were recorded with a probe by an operator other than the surgeon handed the questionnaires and performed the measurement before and after intervention. The required patients were chosen just like literature guidelines, and the procedures before treatment for each patient was given an hygiene session with the instruction to perform the rotary technique with a soft toothbrush and at least 2 months before the operation. The surgical procedures where one surgeon has performed all surgical procedures for reasons related to the preparation of the membrane that must be treated physiologically, must be soaked at least 15 minutes before the surgery. The envelopes were for randomization were opened before the surgery and not during the surgical procedures. The mixed thickness flap, split, full split, was made to MGC in the control group. The sample was taken in the palatal palate from a thickness of about 1 millimeter in the area between the first premolar and the second molar. The graft was stabilized through a cross-compressive suture anchored to the apical periosteum, while for the test group, the membrane wasn't sutured, but inserted into the envelope and stabilized by the flap. The post-surgical instruction, like the guidelines, and the simple size was calculated with statistic analysis, and the results, I show you the results, very interesting, because at the end, the conclusion are the paradigm of mucogingival surgery is to obtain the CRC, the complete cover of the root, in the Miller's second classes with multiple recession without interdontal bone loss, both with the CAF plus CTG, CAF plus bilaminary technique, and with the technique of tunneling of test but plus GTC. This randomized study was designed to evaluate the efficacy of the CAF plus mucoran technique, and we can say that both techniques achieve the completely cover of the roots and prove to be stable at both 3 months, 6 months. Thank you so much for your attention. Thank you. Session allow to clear wood untreated possession area with brush. So always we have to be careful. so we have to wait 3-4 days. We have to use only the normal suggestion about the technique, surgery technique. Then we have to wait for 2-3 days, and then we can start with a soft toothbrush. The second question is, thank you so much for to show it, some bone grafting case. So I think in which kind of membranes I used was the BioGuide from the Gastage for the first layer. After that, I use Mugler. Thank you so much for your attention, and thank you, the botiss. There is another question. Do you change? So, I used, yes, I'm using always in this case for the grafting materials for the to augment the bone where there is atrophy of the bone. I'm using bovine grafting materials. Yes. Thank you so much for your attention.